इंडक्शन जो नहीं है।
Assalamu alaikum. Welcome everyone on board. The topic which I want to discuss today is covering a number of domains of anesthesia. And our patient will be a 70-year-old male presented with acute abdomen. Okay, 70-year-old male with acute abdomen, and that patient is supposed to have some procedure to be done in the abdomen, maybe laparoscopic, maybe open. Okay, so first of all, what are the possibilities that patient can have? For example, if we focus, if we just exclude the causes of other like cholecystitis or biliary tree, if we focus on intestines, so what can be the possible causes? Anyone, please? There may be there is intestinal perforation, there is intestinal obstruction because of any carcinoma, intestinal obstruction because of tuberculosis, or there may be any reason. Okay, so it will be either in the presentation in the form of rupture of intestines with signs and symptoms of peritonitis, or there will be signs and symptoms of intestinal obstruction with nausea, vomiting, absolute or relative intestinal obstruction with nausea, vomiting. And in either of the case, the patient will be hypovolemic. There will be electrolyte imbalance. A patient may be in hypovolemic shock. Okay, so you will be, first of all, you will be evaluating the patient. You will have a discussion with the surgeon about the possible diagnosis and possible plan. They may be doing it open or they may be doing it laparoscopically. The concerns will be a little bit different, but there will be some common things which will be there for either of the technique. That will be replacement or correction of the hypovolemia. Okay, because when the patient is having like intestinal obstruction, this patient will be having significant dehydration. Okay, and if there is for example, there is free fluid in the abdomen, the time they will open it, there will be finishing of the tamponade effect, and patient may go in hypovolemic. Sudden patient will go in shock because of redistribution of the fluid and that removal of the tamponade effect which was there. Okay, so if you are managing such patient, initial preoperative optimization in the form of start of isotonic fluids and looking into the consideration the electrolyte imbalance, if possible correction, whatever you can do, taking large bore IV cannulas. Okay, might be possibility of having a central line. Okay, or arterial line with the possibility of having like a pulse stroke volume variation, so that it will be giving you a good trend about the volume status of the patient. You will be monitoring the urine output. Okay, and you will be relying on the clinical features. So in that way, I am just giving you an overview about this patient. So you will preoperatively, you will have the challenge because this will be an emergency surgery, and you will be discussing with the surgeon what is their plan. Maybe you have some time to optimize the patient. You can take some IV lines, you can start some fluid. You will not delay the patient for tiresome investigations. You can have quick ABGs to see the initial acid base and electrolytes imbalance or anything, because the situation may be variable in different patients. Okay, but as a baseline, you can have ABGs to see the baseline status, and then you will pass NG tube discussion regarding NG tube, that if it is there is obstruction, most probably there will be NG tube But with the NG tube, you should be knowing that placement of NG tube itself is a risk factor for aspiration, because it finishes the lower esophageal sphincter tone and actually predisposed to aspiration, because it will not be able to aspirate the solid component. It will only aspirate the liquid, and still there will be risk of aspiration, especially if the cases of intestinal obstruction. Okay. And history focused on the pre-existing conditions, which will be chances will be more in this age group. We have already discussed the physiological, anatomical, pharmacological changes, and the possibilities of pre-existing condition like diabetes, hypertension, ischemic heart disease. Okay. And limited reserve of the renal system and the liver, and the limited reserve of the respiratory system, limited reserve of the cardiovascular system, impaired responses to normal physiological responses of hemodynamic or respiratory or effect because of the drugs. We have already discussed all those. So these all concerns will already be there. So if anything coexisting, you will be anticipating for that thing. But in either case, in that scenario, in addition to standard 1 and standard 2 monitoring, you will be having intra-arterial blood pressure monitoring and plus minus central CVP line, especially if the patient is hypovolemic. And as I discussed, that the possibility of sepsis. So if you are suspecting peritonitis or fecal matter in the you're suspecting a rupture, or the clinical features of the patient is going towards the signs of sepsis. So you might need to have vasoconstrictor. Okay. So in that scenario, you definitely will be needing central line, because you will be required to give some vasoconstrictor line or epinephrine. Okay. So if we just focus now step by step, preoperatively, I told you that you can have a discussion with the surgeon, optimization in the form of fluid resuscitation, ABGs. You can have a 12-lead ECG, but you will not delay it for too much investigations. You have to proceed with it, because if, for example, patient is there is a condition in which we cannot delay, because as much as you will delay, the patient condition will be more deteriorated. Okay. So what about induction? Abu Bakr, would you like to add something?
Regarding induction, sir?
Yes. What will be your concerns in this patient? How will you induce the patient?
Sir, firstly, we already know if the patient is going for laparotomy, the patient has, along with his age, has compromised all his physiological functions. So we'll go for slow induction.
Okay.
And we'll have adequate flow with the IV line that will help us. As we know, arm brain circulation time is increased. So going slow with good infusion will provide us an opportunity to reduce the dose.
But I will just stop it here. Stop you here. This is one problem which you have, that if you are giving high dose, okay, you can have cardiovascular collapse. But this is one side. The other side is that patient is at risk of aspiration. Okay. So you have to outweigh balance between the risk of aspiration versus the cardiovascular instability. Okay. So you would like to have rapid sequence induction or modified rapid sequence induction? What do you think?
I think we would like to go for modified rapid sequence induction.
Modified rapid sequence induction, you should have rocuronium and sugammadex. Okay. Because if you are giving succinylcholine, you have to give pre-calculated doses of propofol. Okay. Or practically speaking, you can have a combined midazolam, some opioid. Okay. So that will reduce the requirement of propofol. This is your option, but modified rapid sequence induction is a better choice as compared to rapid sequence induction. Okay, but of course you have to prepare yourself for aspiration, because there may be aspiration. This patient is at high risk for aspiration. Okay, so in addition to the mode of induction, you can say that I would like to have arterial blood pressure monitoring at the before induction under local anesthesia, so that you will have more control on the hemodynamics. Okay, and if you are and if you are suspecting that the patient is septic, you can start vasopressor. Okay, before, because for norepinephrine it is better to do via central venous line. So what you can do, that you can start with, you can have phenylephrine infusion. Okay, and later on after induction, when you have central line in place, you can shift it to central line with norepinephrine. Okay, by the way, phenylephrine is the baby of norepinephrine. Norepinephrine is around 100 times more potent than phenylephrine. Okay, because majority of people don't use it, so that's why we are not familiar with it, but you can use it in that scenario. Okay, you should have emergency medications with you when you start such patient, because this patient can collapse even on induction. Okay, so as I discussed before, that you should have good IV lines. You can have intra-arterial blood pressure monitoring before you start. Okay, and you have to take care about the temperature of the room. Okay, you should have adequate amount of warm fluids, because what is distinct, like, let's discuss something about the fluids. We talked about induction, and after that, before they open the abdomen, there are certain things which you should be doing, because when they open the abdomen, and if it was already distended and you are suspecting free fluid, suddenly patient will collapse. Okay, so at that time you have to anticipate, you have to give some fluid before that. And if, for example, patient is having some heart failure to start with, in that patient, you cannot give too much fluid fast. Okay, so better choice will be that you can use colloids. Okay, so colloids will have more intravascular stay, and you need to give a little relatively lesser volume. Okay, so you can use, if you have the availability of albumin, that will be a better choice. Otherwise you can use Hysteril or gelafendin, whatever is available to you. So it is better to give some colloid before they open the abdomen. Okay, because that will be a critical, yes, that will be a critical step. Okay, so how will you calculate the fluid? Like, for example, Abu Bakr, I give you a scenario that this patient is 100 kg, for example. To 100 kg I am giving because of ease of calculation. So this patient is 100 kg, and that patient is NPO since last 24 hours. There is NG tube in situ, and NG secretion is around 500 ml. Okay, so as an anesthetist, they have started a laprotomy, and they have found to have perforated intestine. They are doing a resection anastomosis. Okay, so what will be your fluid resuscitation plan? How much fluid you will give? For example, surgery is lasting for 3 hours. Okay, so how much fluid will you give in this patient of 100 kg with the good ejection fraction? Yes, Abu Bakr.
We have to keep two things in mind. The deficit the patient is having along with the maintenance fluid. Considering the weight to be 100 kg, his deficit would become around 40, 50, 60 plus 80. 140 ml per hour will be the maintenance fluid. And as you have mentioned, we are having 24 hours of NPO.
How have you calculated 100 kg? How have you calculated 140?
For the first 10 kgs, I have
it is 4 to 1. The formula for it is 4 to 1.
4 to 1 with a 4 to 1.
So for 60 kgs,
4 to
it is
1.
100 ml, and for 100 kg, it is 140 ml. Okay. So you found it to be
Yes, yes,
140 ml per hour. Okay. So this is the maintenance.
yes,
So
sir.
for example, if you have
This
10
is the
hours,
maintenance.
usually we have patient is NPO for last 24 hours, for example. Okay. So how much will be the deficit?
So we'll multiply this maintenance fluid of 1 hour by 24, and for
Okay,
that I
just to
might
make
need
it simple, we
calculator.
multiply by 20. Okay, so it is 2.8 liters. Okay,
Yes,
2.8 liters is
it's
the deficit.
2.8 liters. Along
Can
with
you
that, we are having
can you people
500 ml in
can you
NG as
people see
well.
my screen? Can you people see my screen? Okay.
Yes.
And as I told you that there was NG secretion of about 500 ml.
500 ml.
You please mute the mic, please. I request all of you to mute the mic. The people whosoever want to speak out, all of you are welcome. Okay, just raise the hand and let me know. I will. Everyone is open to talk. Okay. So yes, Abu Bakr. So NG secretions 500 ml. Is it isotonic? How will you replace this 500 ml?
This I believe is hypertonic. I'm not sure, sir.
No, you should be sure. This is body secretion. This is isotonic. Okay. Okay, so
Okay, so
it is to be replaced by
isotonic then.
isotonic fluids. Okay, fine. So you have calculated deficit. You have calculated maintenance. Okay. What else? Okay, what else?
Uh,
What else are the?
we have some other losses.
What are those losses?
Safe losses.
I'm sorry.
Insensible losses will
Before
keep the
insensible loss.
insensible
Okay,
losses.
Safe losses.
insensible loss. Okay. What else? The more important thing you are not telling. Third spacing. Okay.
Yeah, third spacing because. Okay.
And if it is open laparotomy, it has around 5 to 8 ml per kg per hour. Okay.
Yes, sir.
And how much is insensible loss?
Around
By the way,
500 to 800 ml.
what is insensible loss, by the way? Loss through where?
Uh, insensible losses are those which go unmonitored by our conventional eye. They are respiratory losses and the losses because of the perspiration.
Yes. Sweating. Okay.
And the ones we are dosing through defecation as well. Don't know how to put it.
This is very disappointing. Please, all of you are requested to mute the mic, please. This is distracting for everyone. Okay. So insensible loss, how can you reduce, by the way, insensible loss? If you are giving humidified air, you can reduce the insensible loss by breathing. Okay. If you are using a humidifier, you can reduce the insensible loss. Am I right?
Yes, sir.
Okay. So it is around 3 to 4 ml per kg per hour. Or 1 to 2.
Yes, sir.
I don't remember.
If the patient is normothermic.
Yes. Okay. Per kg per hour. Okay. So that's, and now other secretions like urine, any other secretion. you have to replace. Okay. What about blood? You will calculate allowable blood loss. Okay. How to calculate allowable blood loss? From preoperative
We need to
hematocrit to allowable hematocrit and blood volume. Okay. How to calculate blood volume? 70 ml per kg in adult male. Okay. So for example, you calculate allowable blood loss as, for example, 500 ml. I'm just giving you an example. Okay. So now the blood loss is 1 liter. Okay. So how will you replace it? Yes. How will you replace this 500 ml and how will you replace the remaining 500? The 500 ml allowable, you can replace it with equal volumes of colloids. Like you can give 500 ml of albumin or 500 ml of hysteril or 500 ml of gelafindin. Okay. Allowable blood loss, you can replace by colloids of equal volume or crystalloid of 3 to 4 times. Okay. So if you want to replace 500 ml of blood loss, which is the allowable blood loss, you can give 500 ml of albumin or 500 ml of hysteril or 500 ml of gelafindin, or you can give 3 times or 4 times, like 2 liters of crystalloid. Okay. Isotonic fluids you can give. We will just lastly, we will consider that how to give it and which fluid should be given among the crystalloids. Okay. So above that, above 500, you have to replace it with the blood. Okay. This is the concept that after allowable blood loss, the rest of the blood volume should be replaced by the blood. That's the concept. Okay. The other thing is that if you are using like for replacement, if the patient is in shock, you can give normal saline, but you will be looking in consideration the rest of the electrolytes like sodium, potassium. Okay. So, and see the acid base status. And would you like to follow some of the blood indices, some of the number, which will help you in looking into consideration the volume status? Do you know? Who will answer? Do you understand my question, Abu Bakr?
No, sir.
I will repeat. What blood result will tell you that the volume status is improving or not improving or not good or what?
Hematocrit.
No.
Hematocrit, I guess.
No. Lactate. Lactate. Okay. If perfusion will be good, lactate levels will not increase. If the perfusion is not good, lactate level will increase. Okay. Agreed or not agreed?
Agreed, sir.
Okay. So we have to follow, we usually, that's why the importance of baseline ABGs. You will have a baseline and then you will follow it. Hematocrit, yes, hematocrit is something for something else. If you have a hemoglobin of coming at 15, but the hematocrit is 30, it means that the blood is hemoconcentrated. I repeat, if you do the ABGs and hemoglobin is 15 and hematocrit should be 45 in that scenario, but hematocrit is 30, it means the blood is hemoconcentrated. And once you start the fluid resuscitation, suddenly the hemoglobin level will fall down. Okay. Understand or no? If the
Understood, sir.
preoperative, if hemoglobin is 15, the hematocrit should be 45. If you see the report, the hemoglobin is showing 15 and hematocrit is only 30, it means this is because of hemoconcentration. Once you will start the fluid resuscitation, suddenly the hemoglobin will fall down significantly. Okay. So that is the effect of giving too much crystalloids. So in resuscitation, when you see that the patient is hypotensive, then you can give either colloids, or among the crystalloids, you can give normal saline. But once you are following it with the ABGs, the balanced salt plasma light is the best one, among all other crystalloids. You can give ringer lactate as well if the liver is good. Okay. So it is better to have resuscitation maybe through colloid or normal saline, and later on you can follow it with the plasma light or ringer lactate. Okay. If you see that there is hypoglycemia, then you can consider half dextrose, but that will be an exception. Otherwise, there is no need to give half dextrose normal saline. Okay. And similarly, if the patient is for example, diabetic, you will be controlling diabetes separately. The resuscitation will be separately, and control of diabetes through the insulin and the fluid, that will be separately. Okay. And what will be the end result? How will you say that the patient is how will you follow the fluid resuscitation? Because that's the most important thing in this scenario. How will you give the fluid? How will you say that you are responding, the patient is responding to the fluid? What will be the things which you can follow?
Serum lactate levels,
Urine output.
urine output.
Urine output. Yes, electrolytes. Yeah, the hemodynamics of the patient. Okay, clinical picture of the patient, the peripheries. Okay, and if you are following the stroke volume variation via this Massimo, there is a Massimo monitor in which you are getting the stroke volume variation even with the pulse oximeter. Or if you have arterial line, you can have stroke volume variation through the waveform. Or if you are having a modern monitors, you can have the stroke volume variation. So you can monitor the fluid status by clinical parameters, by improvement of clinical condition, like the outlook of the patient's skin turgor, patient's mucous membranes. You can see this is one thing. Urine output is other thing. Stroke volume variation is other thing. What else? There is one thing, this is advanced thing, but you can monitor through the T by the stroke, by the vena cava compressibility. Okay. If the vena cava is compressible, it means patient needs more fluid. If the vena cava is already dilated and still patient is hypotensive, then it means the patient needs vasopressors or inotropes according to the situation. Okay. So T is one of the thing by which you can monitor the patient fluid status. At the same time, you should be warned of about the signs of overload. Okay. Signs of overload we discussed yesterday as well in the TURP. There will be bilateral clefts, there may be froth in the form of pulmonary edema, there may be bradycardia, or any of the thing which you can have. Okay. So this is all about fluid management. This is the and one more thing regarding the resection anastomosis. Few words. People say that nitrous oxide is contraindicated to be used in laprotomy. So it's not like that. Okay, you can use nitrous oxide, but specifically when they are doing the anastomosis, you should stop it at that time. Like 15-20 minutes before they are starting the anastomosis, you should stop it. This is point number one. Another point is that when you see that you have adequately resuscitated the patient, when they are doing the anastomosis, look at the gut, ask the surgeon. If you don't have that much experience to see the condition of the gut, ask the surgeon, how is the gut looking? If the gut is looking edematous, you should stop your fluids. you should stop your fluids, because if you give too much fluids or if you give nitrous oxide at this time, there will be serious problems in the anastomosis. I repeat, when they are doing the anastomosis of the gut, at that time, you should not give over fluid. If you are giving too much fluid, there will be gut edema, and the outcome of the anastomosis will be disturbed. Okay, so you have to be very careful about it, because some of the junior residents, they are not interested in looking at the condition of the gut, and they are just happy to do the anastomosis. But you should be taking care of, and an experienced anesthetist should be able to see the status of the intestine and identify what is the status. Okay, so this is two important thing. Nitrous oxide, some people are already against nitrous oxide. There are two groups of anesthetists in the world, some who are not interested in using nitrous oxide. I'm among the people who love nitrous oxide, and I use it in every patient. So there is no contraindication for nitrous oxide unless there are very specific contraindications, but you have to use or discontinue it at specific steps where you think that it can create problems. Okay, so this is one of them. Okay, so we have covered about induction, we have covered about the preoperative assessment, evaluation, monitoring. Now some of the words about analgesia. What analgesia would you like to have? For example, if it is open laparotomy, and what is the importance of giving good analgesia in this patient? Yes. What is the importance of giving good analgesia? If you are not giving good analgesia to this patient is prone to have post-operative pulmonary complications because of stasis. Patient will not be able to cough out the secretion. Patient will have splinting. Patient will have chances of having pneumonia. So this is one of the most important factor, that if you are having a laparotomy, you have to give a very good analgesia. So the choices will be epidural, paravertebral block, erector spiny block, tap block, local infiltration, in addition to the conventional paracetamol, NSAIDs, intraoperatively controlled by dexmedetomidine, lidocaine IV infusion, ketamine infusion, and the opioids, short acting and long acting, and post-operatively by use of PCA. Now we will discuss each and everything, that what will be the pros and cons of everything. Paracetamol usually is safe. You can give it 4-hourly, up to 4 gram, something like that, according to the liver status. Number one. Number two, NSAIDs. NSAIDs are not contraindicated, but some people will be cautious to give NSAIDs in old age because of limited renal reserve, but it is not absolutely contraindicated. You can outweigh risk versus benefit and individualized it. But NSAIDs you can give like ketorolac or diclofenac, or some of the special other NSAIDs which are available in IV in different parts of world. Okay. So I use the word lidocaine infusion. Okay. Some of the people are not familiar with it. Lidocaine IV infusion is one of the thing which is not being used in majority of the setups, because they are not familiar to it. But lidocaine infusion, if you are giving it, it is comparable to blunt the stress response, comparable to epidural intraoperatively. Okay. So how we do, we started around 1 to 2 milligram per kg per hour, 1 to 2 milligram per kg per hour, and we titrate it according to the stress of the surgery. And by the end of the surgery, we can decrease it up to 0.5 milligram per kg per hour, and even we can stop it. The contraindication or things to do will be any liver problem, because lidocaine is metabolized in the liver, and so if liver is not functioning well, you have to be careful. Lidocaine, what is the mechanism of action? As IV analgesic, it is blunting the stress response. It is keeping the it is keeping the hemodynamics as a membrane stabilizing effect, like the same thing which you do at the time of induction. Why you give lidocaine? and you are giving it 1 to 2 milligram per kg bolus. But if I tell you, please start infusion of lidocaine throughout surgery slowly, people are saying, oh, sir, we are only giving it at the time of induction. Oh, sir, we are only giving it at the time of extubation. So in between, is it becoming a big problem? No. Okay. I will share you the article regarding it. And it's a wonderful medication. And especially the people who are doing laparoscopic colorectal surgeries, abdominal surgeries, they have stopped giving epidurals, because epidural is an invasive procedure. And if you can control it with something else, they intraoperatively, they give this lidocaine infusion, and postoperatively, they put the patient on morphine or fentanyl PCA. That's what they are doing in good centers. I use the word of ketamine infusion. Okay, so ketamine infusion, maybe you don't mention it in exams, but practically, I will suggest you to use it in a small dose, 0.25 milligram per kg per hour, similar to lidocaine. You will get a wonderful response. Even if you have a patient with tachycardia, and that tachycardia is because of the stress response, when you start giving ketamine infusion, you will be surprised that instead of having more tachycardia, it will cause the heart rate to slow down. Okay, so ketamine will not be doing bradycardia. Ketamine will be decreasing the stress response. Okay, similar is the dexmedetomidine. Dexmedetomidine is also presynaptic alpha 2 agonist, and it is excellent for pain control. Okay, sorry, to control the response to the pain. It will be reducing the stress response. Okay, so otherwise, if you are giving regional, you can give epidural. You can give epidural for the postoperative pain management as well. Even there are certain laparotomies in a patient in which they are doing intraoperative chemotherapy. Okay, intraoperative chemotherapy, there is a procedure called as HIPEC. They are doing it for it. HIPEC is hyperthermic intraperitoneal chemotherapy. Hyperthermic intraperitoneal chemotherapy. It is being done for specific tumors of genitourinary system and colorectal cancers. Okay, and they are removing the cancer, then they are circulating the chemotherapy under high temperature for around 60 to 90 minutes, and it has excellent effect on the outcome of the patient postoperatively. In that patient, it's a hell painful procedure. They put the epidural and they tunnel it, and they keep it for around 2 weeks. Okay, so you can still use epidurals for postoperative pain management of laparotomy patient having a big midline incision. Okay, then you can use subcostal or tab block. You can use tab block, 20 ml on each side. You can combine it with postoperative this one, morphine PCA or fentanyl PCA as you have available. Another good option now available is erector spiny block. Okay, erector spiny block, there they put the catheter and they can use it just like epidural. Actually, erector spiny block, in real sense, simple words, someone asked, actually the medication is also trickled down to the paravertebral space. So actually is a easy approach of paravertebral block. Okay, so this is another option to do it. We forgot to discuss that such patient in which you are expecting these fluid shifts, acid-base problems, electrolyte imbalance, prolonged surgery, you should have arranged ICU bed, and this patient should go post-operatively to HDU or ICU. Not necessarily that the patient needs post-operative ventilation. At the end of the surgery, you can evaluate, you can have the acid-base status, and accordingly, you can decide whether you should extubate or you should keep intubated. There is no strict indication to keep the patient intubated. If the patient is stabilized and you are having the good response and good parameters for extubation, you can extubate the patient, or you can keep the patient intubated. Okay. So I have tried to cover this topic because there are so many things which are related to this topic. Any questions about this scenario of an elderly patient for abdominal surgery? We tried to cover analgesia, fluid resuscitation, optimization, problems related to the baseline pathology, use of vasopressors, how to control, how to dictate the fluid resuscitation, and that's it. Okay. So any questions, please?
Sir, which epidural we will use for abdominal laparotomy?
Okay. So
Thoracic or
actually,
lumbar?
thoracic. You see, the thing is that what is the basic concept of giving epidural for any Insean? The concept is that you should have epidural around 2 to 3 segments around the Insean. Like for example, if you have a midline Insean that is up to Xiphi sternum, you need up to T4. Okay, so it is better if you give it give the block around T5, T6. Okay. So you will be reducing the dose, because if you are giving in lumbar area, you need to give too much dose. Okay. If you are putting, if you have Insean up to you for which you are needing T4, you should be putting it around T6 so that you the drug will spread to 2 to 3 segments up and 2 to 3 segments down. You will be requiring around 10 ml, for example, or 15 ml. If you are giving it lumbar area and you want to reach it up to T4, you need a lot of dose. Okay.
Okay, sir. Sir, one thing more. Which level? T9 to T10 or T6, 7?
No, I told you T6. If you have Insean, if you have Insean at Xiphi sternum, Insean is T6, but you need block of T4. Okay, because autonomic is T4 above the sensory, and sensory is 2 levels above motor. Okay, so whenever we are talking about laparotomy, we need block up to T4. Okay.
Okay, sir.
Okay,
Sir, one more question.
Yes.
I have read few articles regarding fluid resuscitation, and some authors advocate about less fluid resuscitation as compared to 3:1. They say we can use 2:1 or 1.5:1. What is your opinion about this, sir?
My opinion is that it is better not to follow anyone. See the patient, see the response, see the parameters, see the urine output, see the response to fluid responsiveness. And by the way, I missed that time when you are monitoring the fluid responsiveness by T or by urine output. You can do a very simple test that you can raise the foot side of the patient. If raising the foot side of the patient improve the blood pressure, it means you are on the fluid deficit side. Okay. So actually, these are only to help a guide. It doesn't mean that we calculate 4.1 liter, you have to give 4.1 liter. It will be haram if you don't give 4.1 liter. It's not like that. The best source is that you are giving a fluid challenge, see the response, and then that makes the concept of goal-directed fluid therapy. Okay. So you have to do the goal-directed fluid therapy, whatever formula or whatever calculation you are doing it is just to help you. Okay. You have to keep in consideration the physiological condition of the patient, the physiological condition of the heart, and any other condition. Okay. Yes, Dr. Humera.
Sir, my question is that if there is a pregnant patient and we have to do appendectomy, what type of analgesia do you recommend?
Actually, Dr. Humera, apologies. We are talking about an elderly patient for laparotomy. Try to keep your question near to that one. We will discuss pregnant patient for appendectomy, almost a similar analgesia. You can give tab block, you can give epidural, you can give more PCA. Okay, because if it is in the second or third trimester or first trimester, there is no problem. You can give anything. Okay, but the rest of the things you can give erector spiny block, you can give tab block, you can give epidural. Okay. Yes, Dr. Yusuf.
What about toradol,
tramadol you can give. There is no contraindication.
Thank you, sir.
Yes, Dr. Yusuf.
Assalamu sir.
Walaikum
Sir,
assalam.
my
Yes,
question is that we were discussing the patient.
I'm sorry, please unmute yourself. By mistake, I unmute you. Please.
sorry. Yes, sir.
Yes. Yes.
Yes, sir. Just we were discussing the patient that is almost in the normal uh, condition. I
Okay.
mean, no cardiac issue. But on
Yes.
receiving a patient in the operation theater, just looking at the ECG and X-ray, we find on auscultation that there are some murmurs. As a junior resident, how to proceed in such conditions?
I'm sorry,
We
I
don't
couldn't
have
pick your
a,
question. Can you repeat your question again?
sir, on auscultation of the precordium, if we find there are some murmur in a
Okay.
patient, and it is in our mind that the patient may be a cardiac, there may be some cardiac issue in such a patient. How to
Mhm.
proceed in that condition, in the emergency?
Yeah. Actually, you have to identify what that murmur is. Okay. You not only one finding will not dictate you for the full management. Then you have to see what is the surgical urgency. If it is not urgent, then you can ask for cardiology consultation. You can have ECG. You will go step by step. You will see any risk factor, number one. Okay. Then you will see the urgency of the surgery. Then you will see that what is the hemodynamic status of the patient. Okay. And then you actually, what I told you, that that you will be cautious in giving the fluid. I will take this question from Dr. Peter. Actually, Dr. Peter, you have very correctly pointed it out. The lidocaine infusion, especially if there is some heart condition in which patient is prone to have some arrhythmias, especially the bradyarrhythmias, which can be there in any patient. We are talking about general regime. Okay, so lidocaine infusion is a very nice thing, but of course we have to look into consideration any contraindication. Of course, if there is bradycardia, then you have to be careful. Everything which we use is a risk versus benefit. Okay, Dr. Peter, I hope I answered to your question, your point. You have
thank you very much. Thank you.
You have correctly pointed it out. Thanks a lot. Okay.
Thank you.
Yes. Dr. Yusuf, I hope you understand that if you are saying that you put the stethoscope on the patient and you are hearing murmur, so you will be correlating it with the clinical condition about the heart rate, blood pressure, risk factors. If, for example, the patient is diabetic, hypertensive, and now you are having murmur, maybe you will be looking at the edema. You will be seeing any signs of right and left heart failure. You will be seeing the raised JVP. You will be seeing the pedal edema. You will be seeing the sacral edema. You will be seeing the bilateral craps. If all of these things are there, that will be heading towards a picture of heart failure. Okay, because a murmur is only by murmur you cannot define or designate anything. Okay, if you are only listening something but it is not correlating with anything, maybe you are wrong. Okay, maybe it's not murmur or isolated murmur. If it is an elective procedure, you can get the help of cardiologist or you can seek expert. But remember one thing, other parameters need to be correlated. You don't treat a specific number. You don't treat a specific symptom. You treat the whole patient. Am I right? Even in the ABGs, you don't treat the ABGs. You treat the patient. You treat the clinical condition of the patient. Okay?
Yes, sir.
Yes, magnesium sulfate. Yes, I missed it. Magnesium sulfate is also membrane stabilizing, and it has almost similar effect like lidocaine. Okay, but the same things which we need to be careful for magnesium therapy in any other patient, like renal, like toxic levels, deep tendon reflex, ECG. We should be monitoring them. Okay. Any other question, please?
Okay, sir. Sir, post-operatively oxygenation, you have not mentioned, I think, after laparotomy.
Post-operative oxygenation, because I mentioned in the form of analgesia, if this patient is not receiving good analgesia, this patient will have impaired breathing. Patient will have definitely will have atelectasis, and this will be a vicious cycle leading to pulmonary sequelae. Patient can become
No, sir.
hypoxic.
Another advantage is for gut. We have to give for at least 24 hours
Good
oxygen.
point. Good point. I missed it. This is a point for not only gut anastomosis, it is good for free flaps as well. That you have to give good oxygenation for next certain period of time. Okay, to improve the viability of the gut or the graft. But remember one thing: when oxygen is a medication, if oxygen is so nice, God will have given us, Allah would have given us 100% oxygen, but Allah has only given us 21% oxygen with a purpose. Okay, so you can monitor it with good PO2. You can say that you can monitor good PO2. If the PO2 level is low, you should give supplemental oxygenation. Okay.
Yes, sir. I was about to say that if the patient is maintaining his saturation 99, if the patient is having good PO2, then why to give oxygen? That's my point.
Yes, you have to be target oriented. Okay. The answer is that you should maintain good PO2 post-operatively. If you are maintaining good PO2, then your result is achieved. If not,
Because
then
oxygen can be dangerous for the patient. It can cause oxygen toxicity also.
Oxygen can cause oxygen toxicity. Oxygen can cause acetic acid itself. Okay.
Yes.
So, okay, everybody, thanks a lot. And I will be very happy if you people give feedback on the video and in the WhatsApp. Ask the question so that we have an impulse. I have tried to cover almost common aspects of elderly. We will start some new topic in next time. Yes, Dr. Humera.
Sir, my question is in the chat. What about the oxygen levels? How can we improve the oxygenation in case of torsion
Dr.
of
Humera, we spent at
stomach?
least 15 lectures on respiratory system. I will be very happy if you listen to them. I have discussed each and every point. Oxygenation, how you can improve. Oxygenation, you can improve by giving good oxygen percentage. That you can improve by giving it with the starting from nasal cannula, face mask, oxygen face mask with reservoir bag, with reservoir bag with non-rebreathing valve. That's a way for non-invasively you can increase it. Next step will be CPAP. Next step will be mechanical ventilation. That's how you can improve. Other way is use of hyperbaric oxygen. That's why you can improve the oxygen reserve. Okay. Otherwise, other things will be incentive spirometry. Incentive spirometry, keeping the patient prop up, giving good analgesia, avoiding splinting. Okay. So these are all avoidance of sedation. If the patient is sedated, patient will not be taking the good breaths. This is a risk factor for hypoxia. Okay. Got the answer?
Thank you, sir.
Okay. Bye bye, everyone. Thank you.